So for those of you who don't know me, my name is DJ Betancourt. I have the pleasure of serving as the Commissioner of the New Hampshire Insurance Department, and I want to welcome you to the department's latest public forum entitled The Small Employer Struggle to Offer Health Coverage, a discussion of recent trends and policy options. I feel as though, as I look out at the crowd, this is a bit of a spring training exercise for our annual hearing that is also coming up this fall. But it's great to see so many friendly faces. Some of you I haven't seen in a while, so this is great. The most stressful part of the morning for me is getting through all of the introductions. There are a number of members of our staff that are here. My staff loves this because I never get their titles exactly correct, and we do like promotions right here on the spot, and they love that. But anyway, we'll start with the leadership team. Keith Nyan, the Deputy Commissioner, is here in the back. Next to him is the Assistant Commissioner, Jason Dexter. Michelle Heaton, the head of our Life and Health Division, is here. Our Data Analytics team is here, Dr. Jason Azes and Morgan Harris. The two individuals who have done the yeoman's work, truly, of putting together not only the report, but today's presentation, is Lee Curtis and Alex Feldavel. Their titles are, frankly, not nearly up to the work that they do. They are the utility players, Swiss Army knives of the department. They do incredible work for us. Very appreciative of all of the work that you have put into making today's presentation possible. Tori Fowler is also here. She heads up our Life and Health Compliance Unit. Have I missed anyone? Oh, of course, so we've got our comms team, the folks who make us look and sound good. Andrew Demers and AJ Kierstead is here as well. So as folks know, New Hampshire is a small business state. Small business is the backbone of our economy. And yet we know, and we hear quite frequently from the business community, that they struggle to find affordable health coverage for their employees. That struggle is more pronounced today than ever, as New Hampshire's economy, while very strong overall, continues to struggle to find adequate workforce. And the next generation of workforce has very different expectations as to the benefits that will be available to them in their professional lives. And so helping small employers find that coverage and helping them be competitive to attract the adequate workforce to continue to grow and expand our economy is obviously something that is very, very important to us. At the same time, we also know that our small group market is struggling. And while we are certainly in better shape than our neighboring states, we know that the population, the number of covered lives, has gradually over time continued to shrink as the individual market and self-funded plans have become more and more prominent. When I became commissioner, I had said one of the things that we were going to focus on, and one of the priorities that I had, was understanding the challenges facing the small group market and helping us to better understand what we need to do in reaction to those struggles. What can we do to strengthen our small group market? Or if the landscape is evolving such that the small group market as it looks today is no longer going to be what it looks like in the future, how do we appropriately manage that transition? And so the federal government made an opportunity available for the department to get some funding to look into this issue specifically, and we obviously capitalized on that opportunity. And the culmination of that effort is today's presentation that looks to, in the first instance, appreciate the challenges, what exactly those challenges are, what has brought them about, and then potentially what we're able to do in reaction to them. As always, we are fortunate to be joined by some experts. Our friends at Oliver Wyman Associates are back with us to lead the first part of today's event. Jen Smagula is with us. She is a principal with the actuarial practice of Oliver Wyman. She is based in Boston. And Peter Ketchmark. Peter, hit me with it one more time. I want to make sure I get it right. Ketchmark. Peter Ketchmark, also from Oliver Wyman, is a senior manager in the Milwaukee office. So you had to come travel to see us today. Thank you for coming. Appreciate that very, very much. So we will hand it over to them to go through today's presentation. And then, as you know, we will have a panel discussion later on, and I will introduce the panelists at that time. So if you wouldn't mind coming up, thanks so much.
Okay, we can go on to the next slide. So like the commissioner said, I'm Jen Smagula. I'm a healthcare actuary with Oliver Wyman. I'm joined today with my colleague, Peter Kishmarek, who's also a healthcare actuary with Oliver Wyman. And we're going to walk you through this presentation that's focused on current membership trends in the New Hampshire health insurance markets, along with 3 policy options that we explored on behalf of the NHID. Merging the individual and small group markets, implementing a reinsurance program in the small group market, and then looking at ICRAs and QSARAs. So we can move forward. So the left-hand side of this page shows overall health insurance membership from late 2019 to early 2024 for a couple different segments. The top dark blue line represents total commercial enrollment with health insurance coverage, either purchased in the individual market or offered by an employer. And this includes both fully insured and self-insured arrangements. Enrollment in standard Medicaid is shown in light blue, and the Medicaid expansion population is shown in green. So from shortly around the start of the COVID-19 pandemic in March of 2020 through early 2023, you can see that overall commercial enrollment has decreased slightly in New Hampshire while Medicaid enrollment has increased. During the COVID-19 public health emergency, Medicaid redetermination, which is the process that states use to ensure Medicaid enrollees continue to be eligible for Medicaid coverage, was paused. So during this period, you only see the growth happening in the Medicaid population. Now, continuous coverage of Medicaid ended in April of 2023. So that's when you see this pattern reverse, where Medicaid enrollment starts to drop and commercial enrollment starts to increase. Commercial enrollment is now higher than it has been in recent history. And the Medicaid redetermination process is still an ongoing process, so we'll continue to see how those numbers play out further into 2024. The right-hand side of the chart shows the uninsured rate in New Hampshire compared to all other New England states and compared to the U.S. average. So the uninsured rate in New Hampshire has decreased in recent years, following a similar pattern to what we saw in other New England states and across the whole country. In 2022, the New Hampshire uninsured rate was at 4.9, which is slightly above the average of other New England states, and then below the nationwide average at 8%. So 2022 is the most recent data point available at this time. The 2023 information will be coming out shortly. So this will be another important metric to keep our eye on. Next slide. So this slide now takes that total commercial enrollment from the previous slide, and it separates it into 4 segments. The individual market, which is the dark blue on the bottom, the small group, which is the light blue line, large group fully insured, which is the green line, and then at the very top, the self-insured segment, the yellow. So health insurance markets are typically divided up this way, and while we do track enrollment in all these segments, the insurance department only regulates the insured segments, so that's the bottom 3 lines, the individual, the small group insured, and the large group insured. There's a couple key events that are called out in this slide. So one is the beginning of the COVID-19 pandemic in March of 2020. The next is the start of the New Hampshire Section 1332 waiver state-based reinsurance program, which started January 1st of 2021, and that helped lower rates in the individual market. Next, we get to the American Rescue Plan Act of 2021, or ARPA. So that expanded and enhanced premium subsidies for those in the individual market in 2021, in 2022. Then next, we have the Inflation Reduction Act, which continued those subsidies for another 3 years through 2025. And the subsidies that were put in place through ARPA and extended through the IRA are all helping the individual market. And then, as mentioned previously, we have the Medicaid unwinding process, which started in roughly April of 2023. So that's when people started losing, or some people started losing eligibility for Medicaid. And then lastly, the end of the public health emergency, which was in May of 2023. So as you can see, there's different stories happening with each of these segments. So starting with the top two lines, we've seen the self-insured enrollment. It stayed fairly steady. There was a slight decrease in 21 and 22, but more recently we've seen an increase in that segment. And then you move down to the large group fully insured segment, and there you've seen a steady decrease. And presumably there's some switching happening. There's some shifting from the large group fully insured segment into the self-insured segment. And then now turning to the bottom two lines, while the individual market in dark blue has gained membership due in large part to the reinsurance program that was put in place and the enhanced subsidies from ARPA and the IRA, the small group market has steadily lost membership. So from 2018 to early 2024, the small group market's lost about 10,000 members, or 14%, and it's currently around 60,000, which is lower than where the individual market is at 74,000. So given the membership losses in the small group market that we're seeing here, along with the higher premium levels and trends that we've seen through our annual hearing report, and the relatively small size of this segment, the New Hampshire Insurance Department has chosen to focus on this small group segment for purposes of the discussion today, to both better understand what is causing these enrollment losses and also to explore policy options to help stabilize this market. This slide takes data from the federal MLR reports and compares New Hampshire's small group metrics to other New England states for 2019 and 2022. The left-hand side shows the number of employer groups in the small group market. The middle set of charts is the number of subscribers, and the right-hand side is the number of covered lives or members. So this includes both the subscribers and their dependents. So when you go back to the left-hand side, the number of groups, so this shows there's actually been little change in the number of groups offering coverage. It's pretty much stayed at that 7,500. And where we're seeing the decrease is more in the number of subscribers and the number of members. So the number of subscribers in the small group market have decreased about 5% in this time period, and the number of members has decreased about 8%. So it's not that there are less employers offering coverage, but it's that either the size of those groups or the take-up rate for health insurance within those groups is declining. And it's also interesting to note when you compare New Hampshire to the other New England states, we can see that there's more significant declines happening in the other New England states. From a membership perspective, the other New England states have lost about 13% compared to the 8% in New Hampshire. Now, this slide shows average monthly employee contributions by coverage type over time. So we don't have this information just for New Hampshire. So this is based on nationwide information from the Kaiser Family Foundation. So it shows that over time, nationwide employee coverage towards premiums is increasing at a higher rate for family coverage compared to single coverage. So the family coverage is the light blue line, the single coverage is the darker line on the bottom. So for family coverage over this time, it's increasing about 3.9% per year, compared to single coverage is increasing about 3.5%. And if you dig into this more and just focus on smaller groups, that disparity is even greater. So as dependent coverage becomes less affordable, this may mean that more dependents would qualify for subsidies in the individual market. And this could be one of the reasons why someone may leave their employer coverage to move over to the individual market to take advantage of those premium subsidies. And now I'm going to turn it over to my colleague Peter, who's going to go through the policy options that we explored.
Thank you, Jen. So next we want to discuss what premium rate changes carriers and insured individual and small group market could expect under a merged market scenario in New Hampshire. So just a promise of what's the merged market is basically where you're basically going to combine your experience from the individual and small group market in order to develop your rates. And you would also then offer similar plans in both markets under the merged market scenario. So other states like Maine have implemented a merged market in 2022. And the promise of that is that you basically increase the credibility of the combined experience, and you also kind of stabilize the premium rates. And here we have a list of considerations which the health plans would have to make when they would have to develop the rates in New Hampshire on the merged market. The first item is the claims and provider reimbursement. So any differences in network and provider reimbursement between the markets would have to be aligned since you're offering the same plans on the merged market. Next item is risk adjustment. So just for the background purpose, the risk adjustment is a federal program which basically reimburses carriers with sicker population with payments from carriers which have more healthier population. And this is like a net zero payment program. And currently, both the individual and small group market have separate risk adjustment programs. Under the merged market, we assumed that the state would combine the two risk adjustment programs into one. From our analysis of the risk score differences between the markets, we know that the morbidity in the individual market is a little bit higher versus small group. So in the merged market, this would result that small group carriers have to either receive less or pay more compared to the individual market carriers. Next item is the state reinsurance program. So currently there's a reinsurance program in place in the individual market in New Hampshire. And it does reimburse for large claims dollars as basically the main purpose in order to lower rates in the individual market. You have a merged market, basically you would reimburse for large claims which come from the individual and also small group markets. So if the program is assumed to be the same as far as the size and the reimbursement dollars amounts, basically it will benefit the small group carriers, but it will lower the reimbursement amounts to the individual market carriers. And the two remaining items like exchange user fees and admin expenses, which are shown on this slide, were also considered in our analysis. However, they have a relatively smaller impact on the premium rate differences. Next slide, please. So here on this slide, we show a high-level summary of the potential premium rate impacts under the merged market. On the left, you see a quick overall impact in the market. So in individual markets, their rates would actually increase between 15 to 17%. And in small group markets, the rates would actually decrease between minus 13 and 11%. And on a combined basis, the overall rate impact would be roughly neutral. And the main reasons for the increase in the individual market is due to the provider reimbursement I mentioned on the prior slides, the network differences, and also smaller impact from the lower payments or less payments from the reinsurance program. However, when you look at the middle chart, which shows their impact on all the four carriers which currently are in the individual market, you can see larger differences. So one of the carriers would only see a 2% rate increase, but there are two carriers would have double-digit rate increases of up to 22%. And similar differences we also see in the right charts, which shows their impact on the carriers in the small group market, which varies between reduction up to 20%, but there are some carriers would actually see no change in the rates in the merge market. And again, the main difference by carrier is dependent on the mix of how much business, individual and small group business they have, along with provider network differences and also their what kind of changes in the risk transfer amounts they would expect. Next slide, please. So this analysis of the merge market took into account various data sources and assumptions about the merge market in the rate development. However, if the state or would like to move forward with these options, we have provided less of additional consideration for more in-depth analysis. One item would be, obviously, we just looked at the change in the rates, but we didn't really consider any changes in enrollment. You think about the individual market to double-digit rate increases. There are subsidized enrollees who don't pay the full premium, and they might be mostly shielded from the rate increase. However, in New Hampshire specifically, there is a large section of the individual market who don't receive any subsidies. And if they have to be faced with 20% rate increase on top of the regular trends, that might have negative impact on their enrollment and the morbidity of their merge market pool. Next item to consider is the carrier participation. As we saw, there's large difference between the carriers. And also there are some few carriers in New Hampshire who are only operating either an individual market or a small group market. So how would they react to being forced to offer coverage in both markets? The next item is stability of the single risk pool, which is the main promise of doing a merge market. And as Jen alluded, the small group enrollment is declining on the prior slides in New Hampshire, and now it's becoming actually smaller than individual market. And if this trend continues, eventually the small group market will become unstable and could have negative rate impacts, like a death spiral. So a merge market could be a consideration, maybe not now, but maybe for future. Next item. Yes, next policy options, we looked at the implementing reinsurance program in the small group market. So this is basically would be a reinsurance program which is similar currently in the individual market, where basically the state would reimburse the carriers for any large claims. And we looked at what basically a 5 premium reduction would mean in the small group market. So it will cost roughly, as shown on this chart, and then the call out will cost roughly $20.5 million, or roughly $30 per member a month. And it would reduce the rates from roughly on average $647 per member per month to $615 per member per month, as shown in this chart. So again, this is the small group market. I don't have a breakdown of carrier level. The 10% premium reduction would roughly cost the double amount, so roughly $41 million on an annual basis. The one thing about implementing reinsurance program in small group market versus individual market is that there is no federal funding available technically. In individual markets, the program is financed by some of the past federal pass-through amounts that our state receives. Since there's no subsidy changes in individual and small group market, there's no federal funding available in traditional sense of 1332 waiver. So we estimated that the state, if they would have to find additional source of funding, and they would use an assessment pool of the commercial lives, which is roughly the 450 to 500,000 members. The assessment cost would roughly be $3.80 on a PMPM basis to cover like the $20.5 million program costs for a 5% premium reduction. And last item I just want to mention is that there are alternatives to just offering a reinsurance program. It's something like which Maine has as a direct premium subsidy. So where basically the direct premium subsidy would be probably a bit less risky, where basically the state would basically provide either directly to employers or to the health plans payment on a PMPM basis to reduce the rates in the market. And again, it's a little bit less risky because in comparison to the reinsurance market, you don't deal with the variation of the large claims year over year. And it will also allow the states to direct the funds in a different manner than the reinsurance program. The next item. So the last item I want to discuss is the ICHRAs and KISARAs. Again, these are the alternative healthcare coverage option for small employers. Now I just want to talk quickly about recent trends and what these programs are. So on this slide, before I jumped into discussing the trends, so KISARA, again, this is Qualified Small Employer HRA, and ICHRAs, which stands for Individual Coverage HRA, a special type of health reimbursement arrangements. And again, these are alternatives offering traditional group health plans for employees. Both under the KISARA and ICHRAs, the employer basically provides contributions to a HRA account, and the employee then basically can use these funds to select their own healthcare coverage, either in an individual market or for established third-party platform. The KISARAs are designed for small employers and have various restrictions. They have annual caps on contribution, for example, that must be offered to all full-time employees. In comparison, ICHRAs are less restrictive. They can be offered by all employer sizes. And looking at the charts now, on the left, we show the number of employers offering these two options nationwide. So we don't have the New Hampshire numbers. These are nationwide numbers. So the light green is the number of small group employers offering KISARAs. So we can see that though it's been increasing through 2023, but it's been relatively flat since in 2024. On the other hand, the newly available ICHRAs, which are the darker green, have gained more traction with small employers. So it's roughly, I don't know if you can see this, but like the number of employers nationwide is roughly 5,000 for KISARAs and 5,000 for ICHRAs. And on the right chart, we show the enrollment development or the enrollment changes for KISARAs, light green, relatively flat in 2022 for 2024. But on the other end, the ICHRA has been gaining more, basically more traction, and it's nationwide is roughly less than 200,000 people, but it's growing. Again, this includes all employer sizes, not just small group. But again, in comparison, 200,000 people nationwide, that's still a small portion of the overall, employer-sponsored covered lives, which are roughly 160 million nationwide. So next slide. So what are the health plans' option or strategies and adaptation of these ICHRAs and KISARAs? Basically, some carriers have developed strategies to increase the enrollment in individual market for the ICHRAs, and to see basically these ICHRAs as an opportunity to disrupt the traditional employer-sponsored market and gain market share in the individual market. We mentioned here two carriers like Centene and Oscar. Again, typically these are health plans who have a strong presence in the individual market, but not as much of a strong presence in the small group, fully insured market. Some other plans consider ICHRAs a niche market. So, and in addition to that, so there's kind of like a mixed strategy across the carriers nationwide regarding this ICHRAs. One item I noted here is also that Indiana is one state offering actually tax incentives to employers transitioning from group coverage to ICHRAs, which is roughly $400 in the first year per employee. And again, Indiana, I don't know much details about Indiana, but like I know that the enrollment in the fully insured market has been really declining really fast in Indiana prior to implementing this tax credit. So it actually decreased by a third from 2019 to 2022, and compared to the numbers which Jen compared, the decline for New Hampshire was roughly 10% during the same period. So next slide. So a few considerations for the state related to the ICHRAs and KISARAs. One thing I think important is that, provide better education awareness of the available options for employers, small group employers. And again, this could be the employers who either do not offer coverage, would like to expand coverage, or who are considering dropping existing coverage. Again, the admin costs and the need for education is high initial years of implementing ICHRAs. And And then additionally, on the employee level, there's this complexity that when they go and select a coverage in an individual market, besides just like selecting a bunch of options they have in the individual market, they also have to consider whatever to take premium tax credits, which are available in the individual market, or they opt out of the ICRAS. So they can't have both of them. So they can't take ICRAS and receive premium tax credits. They have to make a decision if the ICRAS are not affordable. So they have this affordability test, which the employees have to basically consider. So that's one of their complexity hurdle on the employee level as well, which, would require better education and awareness as well. The second item for the state to consider would be, how popular these ICRAS and KISARAs could be in New Hampshire. And again, it's going to depend also geographically on the premium rates and network differences between individual and small group market. So in general, the lower the rates are in individual market compared to a small group, there's the greater incentive for employers to either switch to ICRAS or expand ICRAS to specific classes of employees. On the other hand, if the old plans, individual market, have some restricted networks, and more set up like HMOs, and employers who value access to out-of-state facilities like in Boston, they might not consider ICRAS an attractive option. So this might just prevent the traction of expanding ICRAS in your state. And the last one, the tax incentives like in Indiana, they might provide incentives to group with higher risk and lead to adverse selection in individual market. And they might not necessarily help to increase the offer rates among small employers or reduce the overall uninsured rate. So that could probably, providing these tax incentives could be, might have some unintended consequences. So this concludes our presentation. Jen and I are available for Q&A portion of any questions. These slides, along with some additional slides, will be posted by the NIH website after the forum. So thank you very much.
All right. Peter, thank you so much. Excellent job going through the presentation and setting the stage incredibly nicely for our panel discussion. We are running right at time. However, I see that they've booked me for a 15-minute closing remark at the end, and I can assure you that's not going to happen. So if we could, let's just take 5 minutes. Everybody can refresh their beverages, grab a snack, and we'll transition to the panel here. So we'll see you back here in about 5-6 minutes. Thanks. We really do have a phenomenal panel as part of our presentation today. I know the term can sometimes be overused, but these are real experts in the fields that they operate. The bios that I've been given are quite lengthy. I will do the best to highlight the most pertinent and impressive of their achievements and titles. So we are joined this morning by Luca Paris, who is the president and CEO of the Greater Monadnock Collaborative Chamber of Commerce, I believe.
Yep.
He is a former chef and restaurateur, and my favorite part of his bio is that he is a TV and radio personality. My old job, Luca, TV and radio personality. A little bit of a funny story. When we were doing some of our public outreach events, we really did try to get out to and put some focus on Cheshire County. And as part of our most recent trip, Luca was kind enough to invite us to come over to the chamber and have a conversation with him. And he said, if there's anything I can do to help you guys, or if there's a perspective that I could share. And I said, just be careful what you offer, my friend, because we will take you up on that. And so he had to go from Keene to Concord pretty early this morning. So we appreciate you being here to provide a small business perspective.
Not sure you asked for.
Also joining us is Bill Stewart. He is an independent consultant. Bill has spent the last 2 decades working on consumer-driven health initiatives, including health savings accounts, integrated health reimbursement arrangements, and ICRAS. Very important set of background there for our discussion this morning. Kate Skateras, Vice President, Regional Commercial Markets for Point 32 Health, Harvard Pilgrim Healthcare. Thank you, Kate, for joining us. And Maria Prue, President of Anthem Blue Cross and Blue Shield here in New Hampshire. Maria and I have a shared passion for bringing baseball back to the University of New Hampshire. So there's a little bit of a trivia question for you there. To our panelists this morning, just briefly, if you would, share your preliminary reflections, thoughts on the presentation that you heard this morning. Maria, we'll start with you.
Oh, come on. Really? I'm at the end. I'm supposed to go last.
It's fine. Unless we do.
Is it okay? Okay. Good morning, everyone. And thank you to DJ and team for having me here this morning. I said to Alex when we met maybe a week ago to sort of go through the report and just discuss the conclusions, my first reaction to the report was really no reaction, meaning no surprise, right? Nothing that I saw in the report really surprised me or stood out, in a negative or positive way. And I think that's because overall, we study this every day. It's what we do at Anthem. We're constantly looking at trends. We're constantly looking at market shifts, what's causing one segment of the market to grow versus one market to shrink. And I think I always say, and I say this to my team all the time, we're in a business that's very cyclical. Healthcare is very cyclical. And so as you see shifts from one market into another, a year later, you might see a shift back, right? So, when we went into the Affordable Care Act and all of the subsidies expanded and there was a lot more federal dollars coming in, you saw a big shift right into the individual market. You also saw Medicaid expand. So you saw a big shift of individuals moving into Medicaid because they expanded the federal poverty level. And then as we've unwound that, and we've gone through the Medicaid redetermination process in New Hampshire, which we were one of the first states in the country to do it. We started fast, moved quickly, and are pretty much at the end of it at this point. You've now seen a shift back. So you've seen Medicaid go down, you've seen individual go up. But I think at the end of the day, so we're looking at it all the time. So any shifts we saw, in the report didn't surprise us. For us, at the end of the day, regardless of whether we're an individual or small group or large group, for us at Anthem, it's about controlling costs, right? And the better you do controlling costs, the better you will, and what I'm talking about is underlying medical costs. So controlling medical costs at the base level ultimately determines what premiums are going to look like in a market like New Hampshire. And so our focus always, whether it's an individual member, a small group member, a large group member, we don't look at it that way. We have to control costs across all segments. And ultimately, that will help us control what the increase in healthcare costs, health insurance premiums will be in any segment on an annual basis. And so as we look at the shifts between individual and small group, we feel really good about the small group market at Anthem. We feel it's a great market in New Hampshire. We think we've actually taken some steps, whether or not we agreed with some of the steps the department may have taken 10 years ago with legislation. We can look back now and look favorably upon some of those legislative changes that the department brought to the fore 10 plus years ago with trying to sort of protect the small group market and importantly, protect the risk pool, right? Because at the end of the day, if you continue to chip away at your risk pool, that's how ultimately you death spiral and, ultimately lose people in the market. So for us, it's really about staying focused on controlling those underlying medical costs, watching the shifts. And, the other thing, because I know other folks are gonna speak and I can add more later, is, there was a mention by the consultant about plan design. And I think that's the other thing we are very, very focused on at Anthem. As when I talk about controlling medical costs, one of the ways we do that is through plan design. And I don't ever want to underclub the importance of plan design in controlling those underlying medical costs, because we are trying to develop and deliver plan designs in the market, whether it's individual, small group, or large group, that will encourage more consumerism, more engagement of folks who have insurance in the overall healthcare system. Because fundamentally, we believe if we can get people engaged, we can get help and support from everyone in helping to control those underlying medical costs. So, DJ, I'll stop there and just see if there are questions later.
Awesome. Thank you very much, Maria. Bill, your thoughts?
Good morning. I thought it was a really good presentation. I've worked a little bit with Jen and Peter on talking about some of the issues prior to this, so I've been pretty immersed in the project. I hope others got it. I think as my initial reflection is that I think of the words of my favorite living economist, Thomas Sowell, who says, there are no solutions, only trade-offs. And I think that's the one thing that I took away from the presentation, that we can talk about different approaches that the small group market can take from a regulatory perspective. We can talk about what small group owners can do to shift claims, to do various things. But at the end of the day, just to paraphrase Maria, the claims are the claims. These are the costs. We're rearranging, trying to figure out as a state and as individual employers, how are those costs going to be allocated between small group, between non-group? And it's a really difficult task. Ultimately, I think as everybody knows, the problem is that we have a chronic disease epidemic in the United States, and that's what's driving claims, that's what's driving utilization. And without dramatically changing utilization, there's nothing that insurers can do, there's nothing anybody can do except try to play at the margin to make things slightly better. I think of the three solutions that brought forward today, merged market, reinsurance, and ICRA. The benefit of ICRA is that that's something that small groups can do independent of whether there's a reinsurance mechanism or whether there's a merged market. So it's something that employers have in their control. The problem with it is, and we'll get into this more in a Q&A session if people want to get into it, the problem is that if you've got only bad risk groups going into or staying in the small group or non-group market, then the others are able to get out of it through level funded PEOs and other opportunities, then you are getting into that death spiral. And Jen and Peter talked about the death spiral. Maria talked about that. You can't have a scenario where there are easy escape hatches for small groups who have better than average claims and can get out and do something on their own at lower cost. And then if their costs go up, they get to jump right back into the pool. I think that's the danger. So I'll stop there, and we can talk about more issues during the Q&A.
Bill, thank you so much. Kate?
Great. Thank you, DJ. So first of all, I think the focus on the small group market is extremely important. So I just want to say thank you for dedicating some resources to doing this report. In my role at Point 32 Health, I oversee the Harvard Pilgrim Healthcare plans for New Hampshire. So that includes the individual market and the group market, so small group and large group. And from that lens, we're always looking at how the state is doing overall in these segments, right? Because they are risk pools. Specifically for small group, it's treated as a risk pool, right? And so it's extremely concerning to us when we see a 10,000 member decrease in this risk pool over a 5.5-year period. I think the data that we heard from Jen and Peter shows that. And we should be absolutely focused on this piece of our insurance market. It's an engine to our economy. We need to make sure we're thinking of ways to help small employers. And so it's a perfect place to focus for this report. Things that we think about when we look at this report are the tremendous strain that could be impacted in the individual market if the merged market concept is moved forward with, right? So do we want to be putting these increased premiums on our individual market to the benefit of the small group employers? And I think that's to your point, Bill, about there's pushes and pulls we need to think about along the way. It's difficult, and there's certainly more work, I think, that needs to go into analyzing models and what the impact would be. Merged market is one place to look. We have a great example over in Maine that should be studied further as to how the impact of the merged market has gone so far in the last few years. They're seeing double-digit increases year over year, carrier upon carrier. So whether that stabilizes or not, and whether there's a good outcome there for the benefit of that group of members, things will be seen as time goes on for that experience in Maine. But those are things I think we need to focus on, that this report kind of sets a good stage for, but there's more to it that we need to look at. We need to look at the reinsurance program that's been extremely successful, I would submit, for the individual market. And it's not clear we can just replicate that in a merged market scenario. It's got to be rebuilt, rethought through. Perhaps there's additional resources that would need to be applied for a reinsurance program on the small group piece. We need to think about the rate implications, the carrier implications, maintaining competition, how our level monthly funded rules would impact the movement and the volatility between the pools of individuals jumping from place to place, right, as they're looking for, as we've all heard, the best price. So we see that time and time again with our stakeholders. We're always talking to them. We're doing the research. Our consumers, our brokers, our employers, the first thing they think about is price. And that should be really impactful for us as we think about the kind of modeling that we're doing as a state. And so then next comes, quality, how the plans work, et cetera. But price is top of mind, as it should be, right? When DJ mentioned at the beginning of this forum, our small group employers, them looking for employees, trying to sustain their business. This is all part of where we are as a state. So it's important to focus on this. I think the small group market is the perfect place for us to devote our energy. And I would submit it's extremely important that we continue to look at it.
Thank you, Kate. So at, unfortunately, Maria's expense, I intentionally had Luca go last. So the folks you've heard from thus far are obviously people who have spent the entirety or the great bulk of their career in insurance. Luca's background is obviously very, very different. He is a small business owner. He is now a leader and advocate of other small business owners. He is experiencing this dynamic play out in a very, very real way. The practical results of the challenges that we face and hopefully can provide us with some better insights as to what we need to do going forward. So with that little bit of a tee up, Luca, take it away.
Yeah, well, and I was going to say, why am I here, right? And even when the conversation came up of when AJ reached out and said, we'd love you to be on the panel, because I was smart enough or not smart enough to say, hey, whatever you need, I'll be there for you. I said, where do I bring to it? And then you just heard, these between the three of them explaining out what most of you understand because you're in the insurance field. It's what you live in. And I know there's some other chamber presidents on the line and listening. But what does that feel like to the small business owner? DJ started off with, how much we're a small business economy. How much longer before we're not that small business economy? Because there's no way you can afford to be a small business. Add in all the costs that go up. I was 40 years in the restaurant industry. In 1989, I was 21 when I bought my first place. And I've worked for myself until I got the job at the chamber. And now I work for the community. But during that, I always saw a way there was a benefit to owning that place, whether it was in New York or New Hampshire. 3 years ago, I didn't see that anymore. I didn't see where, as every year a new cost was put on us, insurance-wise, the raising costs, the employee costs, where is the benefit to owning a small place, whether it's 10 people that you run or 100, how do you keep that in line? And insurance is one of the biggest things. Now, I just, as a chamber, and we'll touch on a couple of other things, but just as a chamber, we just brought benefit packages, healthcare benefit packages, to our staff. I went from having a staff of one with some part-timers, no insurance, benefit packaging, because they couldn't afford it. And I said, no, our job as an organization is to put our employees first, and we'll cut somewhere else, printer cost or this, cut everywhere else so we could afford benefit packages to compete for the best people. And as going through this exercise, which is great because I went through it right before we got here, I was shocked at how much we're paying. And it was only 2 of the 4 of us that are getting insurance right now, but if all of us jumped on it at the same time, we couldn't have done that. Luckily, I get my insurance through my wife, who works for the school system, which is, you find those little loopholes, and she got a job at the school system, so I didn't have to pay for insurance as a business owner. We have to do those things, and it's that trade-off thing, right? You mentioned it's like there is no solution to this. It's just how do we find a way around it? Our whole economy is based on rational choices, right? We know the value of something and we pay for it. And I think as a business owner, representative, we have no idea what we're paying for. And I know a lot of you understood what was on that chart and these charts in this presentation. I glazed over, and I've seen this before this happened. I looked at it again, and I still don't understand it. And there's a problem with how we explain that to our business owners and leaders. I don't think there's a total disconnect. I talked to you before about that you're speaking a different language than I understand. You're telling me something this is the way we could fix this, but I have no idea, and the only thing I think about is how much is it costing me. But I have to understand the value of what I'm paying for too. Once you understand the value as a business owner, you could do it. You'll say, oh, this makes sense. But if you don't, and most of us are too busy running what we're doing, and that's why it's so important for organizations or businesses, for us in our example, the Richards Group, who had to come out and show me everything and give us a booklet this big, was reading that, they could put anything in there. We have to trust in what the system is bringing us. So that's just the tip of the iceberg. Understanding the value of what we're doing, making sure we're watching costs, but how much longer can these businesses afford to pay this? That's pretty much what I leave it at.
But thank you so much. So my staff did not provide me with questions for this panel. They left it to me to do that, so hopefully these questions are all right, but I've tried to design them such that if you don't like them, you can run off in any direction you'd like. All of you have kind of mentioned the fact that we want to try to avoid the big crisis. We want to make sure that we're not having to manage the death spiral, which is why we've, as a department, put such focus on this issue. The crises are obviously much more manageable when they're smaller and when you have a greater number of options that are available to you to bring to bear than when you've got your 5-alarm fire, if you will. As we saw in the presentation, New Hampshire is fortunate in that our trends are more gradual, somewhat more stable, but the long-term trend is obviously still not where we want it to be. And so Maria mentioned that New Hampshire has made some policy choices that have better positioned us. And then we've obviously heard this morning 3 pretty dramatic potential solutions. And so my question is, are there other smaller steps that we can take in the interim as a state that we can bring before policymakers for them to consider? But also part of that, are there things that you are seeing in other states that have proven to be unhelpful, things that we should avoid? Because appropriate for our discussion this morning, to borrow the medical term, we first want to do no harm. So I'll ask that question of our 3 insurance specialists, and then Luca, I'll have a special question for you.
I'm so scared.
No, you're all good. We'll take care of you, my friend. Kate, we'll go in reverse order this time, if that's all right.
Okay, perfect. So small steps, I would say, in the spirit of a priced focus lens, right? So we heard that that's an important piece to it. I know you said price and then value. What am I getting? In the spirit of price, similar to what Bill was commenting on about these mechanisms to help manage price. So the tools available, ICRAs, QSERAs, level monthly funding. These are things small group employers work with their brokers to think through the impact on price for what they're paying for. Now, those are tools that I think we should probably look at as far as, like I mentioned, the level monthly funding product rules in New Hampshire. But we also need to, in the spirit of push-pull, remember any of those tools that a small group business avails themselves of, removes themselves from the group pool, right? And so to Bill's point, if they're looking at those options and they seem more reasonable, each of them has a different kind of basic footprint for how the employer is operating as the healthcare needs of its employees evolve. So if you're looking at an ICHRA, an employer might be thinking, this is costing me too much to be in these markets. I'm just going to give dollars to my employees and say, go purchase insurance. Here's a start. Go to the individual market. Now they're leaving the small group market and moving into the individual market. What is that doing to the risk pool? Are they truly in need of more services? Are they more costly? Do they have RX needs that we don't know what that volatility, that's what I was referring to, is going to bring. Similarly, with level monthly funding, right? You're analyzing as a small group employer with your broker, what are the claims looking like? What is the true cost to my employee base's need for care? And maybe it looks really good for that year, right? So you're taking this good risk out of the individual market, putting it into a level monthly funding product. Next year comes around, there's a huge increase on what they're paying as a level monthly fund. They're back to the individual market or the small group market. So we need to just think about in some modeling how that volatility is going to impact price as the starting point, right? It's on the broker community that we work with and ourselves to make sure there's comprehension on the value and what you're buying. But from that price lens, that's what I would initially offer.
Kate, thanks so much. Bill?
Yeah, I think the point I made earlier was that you've got to find a way to make that door in the small group market swing only one way so that people can't get out and get in. As Kate says, when the claims look good one year, I'm out. When they look bad the next year, get back in. The problem is that you really don't have that leverage as a commissioner. That doesn't exist. The small group has to be guarantee issue. It has to be community rated. When ICHRAS first came out, I had a discussion with the deputy commissioner of insurance in Massachusetts, and he said, Bill, what can I do here? I mean, this is, if you think back, the Trump administration had three major initiatives. Number one was increasing the span of coverage on a short-term limited duration plan from 3 months to 36 months. The second thing was the association health plans, making those rules looser so that more organizations could join together. And the third one was ICHRAS. And I said, Kevin, those first two you have a lot of control over because that's insurance. ICHRAS, you can't really stop them if somebody wants to do that because that's not anything that insurance commissioners can regulate. That's a funding mechanism, not a coverage mechanism. So, and then the third thing is, this level funded going to a self-insured model. Well, again, the ERISA exemption, Department of Insurance can't do anything about that. So you're kind of stuck. You've got this market and you're trying to make the best of it, but there's still, because of federal law, there's an ability to game that system, and if that bet doesn't pay off, to get back in with no penalty. And that's what makes it really hard to do something structurally meaningful that's going to have a long-term impact here. So I hate being a pessimist. There are some things that can't be, reinsurance, that's an interesting concept that may help, but you don't have all the levers available that you would have if this market were being governed by the state and not a combination of the state and federal government.
Bill, thank you very much. As right as you are, it is nevertheless rather depressing.
Sorry.
What?
Maria, your thoughts?
Depressed. I think we can find solutions. No.
Anytime somebody tells me I have less authority than I like to think I have, it's a sad thing for me. It hurts my feelings.
So, just listening to the other panelists, who I agree with a lot of what I'm hearing, I think, and I go back to Luca, because we were on a prep call together, and how you talk about what we're talking about today. To someone like Luca, who's not in industry, but it's really important for Luca to understand some of this. Mm-hmm. And I think I'd always take a step back and say macro versus micro, right? The concern with a report like this, right, can be that you are so focused on a micro segment, right? Insurance is much bigger than just small group, right? We've heard it. It's ICRA, it's small group, it's level funded and large group, it's ASO, it's all of these things. And so when I think about what you can or can't or shouldn't do from a policy perspective, I think from my perspective, it's making sure that as we're all out there talking to policymakers or regulators, that we're focused both on macro and micro. Because we do have a citizens legislature in New Hampshire who can get very focused on the micro because their neighbor has one problem that then turns into a piece of legislation. That's the danger when you're working in a pooled risk environment, which is what we're all working in. And so, yes, you have to understand the micro movers in the small group segment, what might push them out, what might bring them in. But you have to look at the macro market and say, what is going on in the insurance market in New Hampshire more broadly? And there's one stat that was in the report that was mentioned that I think we have to remember, 4.9%. 4.9% is the uninsured rate in New Hampshire. And what you saw in the analysis is that hasn't gone up, that hasn't gone down. That's a good thing, right? We don't want folks going uninsured. I think we can all agree on that. We can all agree that in a pooled risk, the way insurance works, we need more people to be insured, not less. And so for us, you take that step back and you say, are the market forces, are the policy decisions forcing more people to just say, I'm not going to get coverage? We're not seeing that. So I think that's where I won't get depressed, DJ. I'll say that's really good in New Hampshire, that we're not, with all those little dot points and lines where the graphs you were glazing over, oh, this happened and then this happened. And there's a lot that has happened in this country over the last, with COVID in the world. And we didn't see large spikes in the uninsured rate going up and down and up and down. That's good, right? So it's, for me, it's that macro, look at overall where the market is. But then, yes, are there micro factors that we have to address? I mean, one of the biggest realities of the state of New Hampshire is we are the second oldest state in the country. That's our reality in this state. When we talk about healthcare costs, that's a problem, because we've all agreed the underlying reason premiums are going up is because underlying medical costs are going up. As you age, you generally use more services, which means more costs in the system. So when I think about the policy pieces, I'm thinking not about healthcare. I'm thinking about housing. I'm thinking about education. I'm thinking about the lack of childcare in the state. I'm thinking about the lack of employees, the lack of young people staying in the state and working. Healthcare, we then receive all of this, right? We have to deal with all of these other factors that are impacting our industry. So, and I would encourage you all, the BIA is doing a lot of work also across the state, just doing roundtables, hearing from businesses about what their biggest problems are. Healthcare is not even on the list. Mm-hmm. It's housing, it's employment, it's childcare. So for me, that's the macro, and all of what goes on in all of those other areas impacts the costs of healthcare. So I think, I think we can't overreact to stuff like this. We can't underreact, but we have to be responsible with how we talk about it.
Thank you.
Before you ask my question.
Sure, please. Jump on in.
I love the fact that you have the pessimist in Bill and then the optimist and Maria down by on that end.
Maria did help pull me out of
I love the way it's that. But I do want to just mention something, Maria, about what you're saying. And part of what our mission is at the Collaborative is promoting the region, in our case, our region, and helping New Hampshire promote to the next generation of workforce and the people that live here. Mm. And yes, those are the three items that pop up, right? It's housing, it's childcare, and it's what was the other one? Remember, workforce. But we have to bring that next generation in. I think, what was it, about 12,000 births for 1 million people over the last year. I mean, that kind of, we're not making enough people here to balance out the aging population to the young. And if you balance out the pool, you have more people paying in, right? Is that what you're saying?
Exactly. See, you are an expert.
No, I'm not. No. Well, but I'm seeing it from our end about how important it is to not become a retirement state, because if we're that, then the cost of healthcare is going to go through the roof. So it's going to be hard to retain these people. But what we have to do as the collaborative and the chamber and work with the state on the BEA level, the BIA, and all these organizations is help recruit those people to this area to fill these jobs that are going vacant. And so that's a big part of what we're doing. So I see that on a big level. And then, Kate, just to mention something, you mentioned about Maine. I use this term in the restaurant business. We do R&D, which is, well, we translate it to rip off and duplicate. Have you used that?
Oh, absolutely.
Yeah,
We're
yeah.
doing
So
that with our
R&D,
risk mitigation
so you
program
find
for homeowners
something
insurance.
you really like somewhere else, and you go, oh my gosh, I want to make that. Now you do it in your own vision. But in the case of Maine, or so finding those rural type states that are doing this well and getting through these processes and kind of duplicating that in the vision that works well here, I think is really important to think about. So,
Luca, thank you very much. So my question for you is,
oh, I still have to go? I thought I got out of
well, you did well. We're gonna keep it rolling, man. One of the things that is very important to me as a policymaker, policy guider, if you will, is to constantly check my premises and assumptions. And one of the ways that we've tried to do that as a department is to get out into the community and talk to members of the public who are living this experience every day. Whatever issue it is we're trying to address, we want to understand what the day-to-day experience is like. For better or worse, I've been kicking around public service for about 20 years. I had the benefit to watch very intimately two governors who did a phenomenal job at getting out into the public, getting outside of Planet Concord, as I like to call it. When I was a legislator, I watched Governor Lynch do it very successfully. And then I worked for a number of years for Governor Sununu, who I think has done it very, very successfully. So I think you've confirmed for me one of my core premises already, which is that we need to do a better job of increasing what I call insurance literacy amongst members of the public to help you all understand, to your point, what it is you're getting, how all of this works, and putting that into terms that the average citizen can understand, those who are not insurance experts can understand. The other premise, though, that I'd like you to either disavow or firm up is it not in fact the case that this next generation of worker has very different expectations about the types of coverage that will be available to them? I think we've certainly, departed from the traditional mindset of workforce, which is I'm going to go work for this company for 20, 25, 30 years, punch in 9 to 5, walk out at the end of my career with a nice pension. What are you seeing from the current workforce, and what are their expectations as it pertains to their health coverages?
So on the first part, it is, and it's something that I find incredibly uplifting, is what your department is doing, is actually going out in the community and having these conversations. I've had AJ on my radio show, so it was really cool, because I cringed when we said we're going to talk about insurance for 24 minutes. I thought no one's going to want to listen. At the end of it, I was like, that was exciting. I was like, who would say, oh, maybe you guys, but no one else in the world will find this exciting, right? But there was so much information, and that's the thing. First of all, there's so much information. Second of all, how it's sent out to us, if it's a 3-page, whatever, email or this or that, I think it just has to be dumbed down to who's there. In a lot of ways, when Maria was saying something about, speaking to Luca, I was like, oh, I'm like the second grader on the panel and I didn't mean that in a bad way, but it really is. You have to talk to us in the language we are, right? And again, I think that's from the first thing I said. And I think it's really important, but to keep telling that message, utilize the resources we have now that we've never had before these last 10 years, which is that social media impact, and make it so people want to kind of absorb the information in 30-second sound bites and in a minute, or a chart that kind of is more animated and people can understand. Make it so they understand it on a business level. So I think just keep doing what we're doing is important. And reaching out to organizations like mine and the chambers and the BEA and the BIA, so that when they go out, they can tell the story for you. Really, it's, again, let's do the restaurant analysis or the restaurant equivalent, is that my biggest promoters are the people that had dinner at the place and went out and told somebody else and explained what their experience was. Not me, them, right? And that's what really tells the story. So if you could teach me to tell the story, it's going to be so much more important than you trying to tell it. So that's one. On the second point, and I know some of you in the audience are in the same age group I am. I have a 22 and a 21-year-old. They were really close together. He turns 23 next month, so it's not that bad. But one's in the workforce, the other one's finishing up her senior year at college. And from what I've seen from the people that are getting out there, it's a completely different workforce we're dealing with. This Generation Z and going into Generation Alpha or Generation A, they are thinking about how much time they work, where they work, and what their benefit is going to be about working. And that is the most important part about work for them. Not when I started, the fact that I would take 100 hours of my week and dedicate it to my business because that was what my father taught me. This is a whole different world. I've had the conversations with my kids too, and I'm sure you have, about, I would be like, guys, just go early, go an hour early. What do you mean go an hour early? Stay with the business what do you mean stay with the business for a long time? It's very different. It's unique to their generation, which we have to now understand. That's, again, understanding how to speak to them and how they speak to us. So they're going to be looking for a whole different thing from the insurance pool. They're going to be looking for a reason why they should be involved in our state. So we have to talk to their language too. I think it's a whole another issue you're going to run into in the next 5 to 10 years. And when we have no data about how to deal with them. And that's the craziest thing about it. And I just interviewed for a new position. It was a membership coordinator position. Someone in their 50s interviewed with us, and then someone in their 20s. And the viewpoint of how they were going to attack this job was so different. But I'm not saying it was good or bad. It was really refreshing to talk to the young lady in her 20s about what she expected and how she expressed what she wanted from her job with us and what she would give back. So I don't know how that reflects in their insurance needs, but it's a whole different grouping of people we're working with.
Oh, look, that's great. Thank you very, very much. So last question, and then we are going to throw it out to questions from the audience. So obviously we've heard this morning 3 pretty dramatic solutions to potentially shoring up the small group market. Not to be biased or critical of any of them, but Kate pointed out the fact that Maine went the route of the merged market, and the results there have been not ideal, I think it's safe to say. What are your thoughts on the merged market? Have there been states that have done it where it's worked out better for them? I'll throw it out to whoever would like to take that first.
Well, I think Mass did it first, right? I mean, Mass has been merged. They're probably the market we could learn the most from. Definitely, good and bad.
Yeah, it's been 20 years in Mass. Yeah.
And we've seen what's happened in Mass, and we see the costs, and we see Mass consistently at the top of healthcare costs in the country. So I think again, you can learn from, what maybe you like. I think, Luca, you said, let's learn things that you could do. You look at the markets, you study the data, and then you say, what's good, what's bad, and can we come up with our own solution that combines the two, or balances the two, I should say. And I think, but we're not seeing, if you look at what's happening in Massachusetts, you're seeing a further degradation of the small group market in Massachusetts, right? The costs are just growing, and we're not seeing that they've been able to shore up small business and coverage for small business. So I think, but there's all kinds of other reasons for that. And what I would say is at the top of the list is underlying healthcare costs. And if you look at Massachusetts and what goes on their price, I happen to run a plan in New Hampshire. I actually run a plan in Massachusetts as well. Very, very different, extremely different. And what I deal with providers in Massachusetts, very different than what I'm dealing with providers in New Hampshire. So I think there's reasons for that. In Maine, I think it's too new. I mean, it just went live, this past year. So I think we've got to give it some time. But what we can also see, maybe not the merge market, look what's going on in Vermont right now. Vermont's in trouble, right? That's a market where you talked about before, don't wait till the house is on fire. That house is on fire, and they've got big problems. And I think, going back to your question to Luca and Luca's comments, one thing that struck me is when you talked about the terminology you use. It has always struck me. I've been in this industry now 17 years, and in no other industry do we always say it's free. No one says I'm getting a car today and it's free. I'm getting a refrigerator and it's free. Mm-hmm. But we talk in healthcare and we talk about free healthcare. Like the lab tech that's drawing your blood doesn't work for free. So maybe you as a consumer don't have a copay when you walk in the door, but it still costs money. And I think one of the things when we talk literacy or we say, how can we talk about this differently to help educate? I think eliminating this concept of free, especially I would have really liked to have asked the 20-year-old what she thought about healthcare. Like, does she use the word free, or is there an expectation in that generation? No, I'm going to have to pay for something. Like, that's just how the world works. Versus, say, the 50-year-old who still thinks free is real. And I always try to say, nothing's free. And it's, by the way, it's not our money. Anthem, it's not, it's your money. You pay us premium. We turn around and we pay your claims. So I think, as you think about the consumer piece and literacy, I would be really interested to understand from your perspective about this word free and, does it drive a lot when you do get into the boring insurance conversations, which you try to avoid? Is that a problem?
Well, I think you mentioned it. When we go to the doctor, everything's free, right? Because I have yet to pay. My wife mails a $20 check, I think. I don't know. I guess. But I know it does. I know she does because I don't worry about it. But it feels like that, even though the insurance is paying for it. So, so it's not free. I get it.
Right.
But we don't think that way.
Exactly.
And then, that you get a knee replaced, you think it's free. And then you get a bill.
And you're like, oh my God.
Why am I paying that?
Right.
Yeah, that's a deeper conversation.
Yeah.
But yeah, that happens.
So a couple comments. First of all, you're in the insurance world now. Just the talk. You're in it. You're thinking about it like we are. Just to pivot back to your setup, DJ. So when we look at other states, those are important examples that we can study because we want to make sure we're learning from experiences. Massachusetts, we need to be careful with that comparison. There's 7 million people that live in Massachusetts. We have 1.4 million in Maine. We got to think about the population size when we think about that. Another concept I think we should look at is exploring an expansion of the definition of small group to include perhaps 2 to 100 FTE business sizes. Something to model. I'd model it out. I don't know if other states have done it for an experience review, but it's something we should think about in the state of New Hampshire. The other comment I want to make is regarding understanding what you're buying and the value. So we've talked a lot about that. That's something that we think about a lot at Harvard Pilgrim Healthcare. Here's an interesting fact. Consumers purchasing their own coverage, studies show it takes 3 years for them to understand what they're buying and actually getting that meets their needs. So I've made a lot of comments about price is top of mind. The immediate next element is the value of what I'm getting. And that takes the cake on price when people understand what they need, what they're getting from their health plan. When they come to Harvard Pilgrim Healthcare, we're answering the phone in a very timely way. We're helping work with their provider community to get them what they need for their claims experience, allowing them exceptions, making sure we're working with them to get the best out of their health plan for what their needs provide. The education piece is so critical when we think about how we're going to evolve as a community. So a lot of good points here today. A lot of further modeling would be good, taking these things in mind.
Bill, thoughts?
I just want to make a quick point about some of Maria's comments. And I had a boss when I worked for Harvard Pilgrim. I was there 19 years, so I know the insurance stuff the way these two do too. So I'm one of those veterans. My boss said, the problem is that we think we're selling insurance and people think they're buying coverage. And I think that gets to Maria's point. I mean, how many of us say, you know what? I haven't used my auto insurance for the last 5 years. I'm going to wreck my car. I haven't had a claim for my homeowners for 20 years. I'm going to toss a match and see what happens. And yet when we've met our deductible on the medical plan, suddenly, I'm going to get this, I'm going to get that. It's been bothering me. I don't want to get the physical therapy for that when I have to pay for it. But if it's free, if it's 100% covered, then yeah, suddenly it's worth it to me. And that's one of the things that we have to break that idea to people, because as she said, it's not Anthem's money. It's employees don't understand. It's their money that they're spending when they get those services that are lower value to them just because the insurer is paying 100%. That's money that's coming out of their company's compensation budget next year. And they gotta realize that it is their money and they need to spend every dollar, but prudently, not just the dollar below the deductible. And the other point I want to make in Massachusetts, talk about that a little bit. I am from Massachusetts. Sorry. Yeah.
Did you know that?
Yeah.
We'll look into it. We'll have better screening for the next one.
But let me make a key point. Did any of you ever eat at Foodies in Concord? Okay. I co-owned that for a number of years with a business partner. So I did have a New Hampshire business, even living in Massachusetts. Of course, it folded. But the point is, Massachusetts has had this model for 20 years, and Kate's right. It's a much bigger state, so we can't draw conclusions. I will tell you one of the areas of concern in Massachusetts, particularly among the retailer associations, is they want to break the merged market because it's costing small businesses. In Massachusetts, the small group is subsidizing the non-group. So smaller businesses, Luca, are paying a premium to subsidize the individual market, and they want to get out. So again, it's one of many factors, but there are no solutions, only trade-offs. And in Massachusetts, that trade-off is that one group's paying more so that another pays less.
So we are going to open things up now to audience questions, I guess, to kind of wrap up that discussion. Luca, what you're hearing is sometimes the R&D ripoff and duplicate is great, and other times you observe and run away.
Well, that's it, and that's part of it.
Sometimes that also is just as important. I think one thing that everybody has stressed here that I think is really a timeless point is to be cognizant of cost. I think that for all generations, obviously, the affordability of whatever product or commodity they need is always going to be important. I think that's consistent and here to stay. The challenge, though, and I think the discussion and the big issue that all of us have to work through is somebody had made the point of the cost versus the value. Because I think that's where this next generation is having a little bit of a hard time appreciating that dynamic, in the sense that the younger folks that we talk with, they want something that's affordable, but they also want vast networks. They want access to Boston hospitals. They want, affordable premiums, very low copays, all of that stuff. And it's in that friction that you really see the need for a more robust discussion about that cost versus value piece. And I think that's probably something that all of us are going to have to think a little bit about in our discussions in public forums such as this. So Andrew's got the microphone. We will bring it around.
Before we do that, I want to invite our online attendees to ask their questions in the chat. So if you have a question and you're viewing online, please type into the chat and we'll address either the presenters or the panelists. I didn't think when I was driving here we'd get into Thomas Sowell and Milton Friedman, so that's pretty awesome. The no free lunch thing, that's great. We have a couple of questions from the online participants, and I think the first one is probably geared towards the presenters, though certainly panelists are welcome to chime in as well. They ask if the small group market is shrinking due to the age of employees or older adults going to Medicare or some other reason.
So let's see. Is the small group market shrinking because of the age of the employees? Moving on to Medicare is a question. I think that is definitely. I mean, that is definitely part of it. I'm trying to think. I think in the other analysis we've done, the overall age of the small group market itself hasn't changed that much. So there's not. It doesn't appear there's a ton of. I mean, if people are leaving, there, it must mean that there's new people coming in younger to kind of keep that overall average age pretty stable. So I wouldn't, but I mean, yes, it definitely, there's obviously are people leaving small group market as they start to age out into Medicare, but it doesn't seem to be dramatically changing the age of the small group market overall.
Anything from the panelists?
Well, I would just, pick up on that and say there's other options available. So I think importantly, this study found the number of small businesses has not shrunk in New Hampshire purchasing coverage. Just the dependent subscribers, members on the plan has shrunk. So I think, to your point, it could be aging into Medicare, but also we talked about the ICHRA. It could be dependents not taking the plan anymore and going off and buying their own individual coverage. I think also employers have had to make very difficult decisions about even coverage for dependents. Whereas normally an employer would cover you and your spouse, now employers are charging a surcharge to cover the spouse. And so in those situations, you might see the spouse and the children go off and buy their own policy. So I think all of those factors are probably weighing.
Thank you. We have a comment that's sort of also a question, and we hear this as we go around the state and speak to people like Luca and have conversations with small business owners across the state. We hear all the time, why isn't it easier for your restaurants to band together or for, like businesses to band together? So this person asks, why not mirror the SBA definition for a, quote, small business in the small group category?
So what does that mean?
Yeah, I don't think I know what the SBA piece is.
Small Business Association.
No, I know what that is. I don't know what the definition piece is. But what I would say is, essentially they're just asking, let them create their own risk pool. And I think I go back to many of the comments on the panel today. That just takes the healthy risk out of the bigger risk pool, puts it in its own risk pool, and leaves the sicker behind. And unless you're very careful, and I think, Kate, you made this point very well earlier, and Bill, you did too, about the jumping between pools. You're just chasing a price back and forth, and ultimately your risk pool will death spiral.
I think that Luca brings up an interesting point, which is, when we go around the state, we hear people speaking two different languages, so to speak. So that might be part of the education thing that we need to do a better job on.
Andrew, if I may, I think what the question speaks to is the concept of association health plans, multiple employer welfare arrangements. To me, we could do an entire 2-hour forum just on that. What I will say very simply, though, is both state and federal regulations that are currently in place right now greatly inhibit the ability for those to be viable, in addition to the policy considerations that Maria just talked about. So we can certainly dive into that issue deeper with the individual who had that question, but put simply, that's the dynamic there.
And I would also point out, when you get those groups together, it's really hard to keep them together. New Hampshire, 10, 15 years ago, I was working with a group of like businesses that went off and self-insured, and that worked for them until a couple of the businesses found out they were subsidizing the rest of them. They realized that their claims experience was better than everybody else's, and then they jumped, and that pool quickly went into a death spiral as others figured out they were subsidizing. So number one, as Maria said, it takes good risk out of the small group pool because you wouldn't be getting out if it didn't. And number two, keeping those together, you're going to get that same problem. The good ones are going to find a way to get out because they don't want to subsidize forever.
And pool size, which is part of the reason why we're here talking about the small group market, right? Like how big of a group can you pull together? And it needs to be big enough to be able to manage the risk associated with the claims.
Lucy, if you would. Andrew, would you bring up the microphone? And Andrew, is your hand up as well?
I'm really good. Pretty good here, and thank you all for coming to the law school for this conversation. Luca, have a question for you, which is you said the underlying issue is really cost, but you don't quite always understand the value of what you're buying. Mm-hmm. And it sounds like the value is both the insurance design, but also the healthcare delivery system design.
Yep.
What would help you understand the value of the healthcare system that you're buying? And for the carriers, you know, what solution actually changes that dynamic around what the employers are buying for health system?
So I think when I use that R&D term, it doesn't only mean to like find another solution that someone else is doing and doing it right, but also how you present the value. All of us have a value basis of what we think we would pay for something. There's some of us, I don't care what it is, a car that costs $100,000. Maybe those of you in the insurance companies can pay that, but not a restaurant unless you're from Mass, then forget it. But what I'm saying is that value for that car is inherent to you, right? And would I pay that kind of money? No, I wouldn't. I'd only pay this much for this, and this is where I'm going to be. I think we have to, as you guys have to, as an industry, is create the value for doing it. It's the same thing with me in membership. Why join a Chamber of Commerce? And, you know, Michelle's on there and she'll say the same thing. We have to create the value or explain the value based on the individual. Now, I now see the value to price. That's why we are putting our people first and making sure they have insurance as an organization. But how do you do that on a bigger base, right? On a larger scale is showing the value. Price is not going down. I wish you guys could get the price down on medical supplies or taking care of people. It's not going to go down. Insurance is not going to go down unless we get more younger people than older people, and then of course, I'm sure that affects it. Is that right? If we have more younger people than older people, our insurance will go down.
Individual issues,
I
right?
learned about what insurance is. It's amazing.
It's about utilization of services, so you can have older people that just are very healthy,
Right.
because they're taking care of themselves and they don't use a lot of services.
But on average, your statement is right. The younger,
On the lowest level.
yeah.
So, but I think is explaining the value and sharing that in a way that we could kind of digest well. I think that's the biggest thing that we have to do. And I don't know the answer to that. It's, how do we do that?
Well, and I'll just comment also, who's buying it? Is it the individual going on healthcare.gov? Mm-hmm. You're meeting with their broker, picking the plan for them. To your point, it gets really personal, right? Like, what are your personal healthcare needs? Or is it an employer saying, what are my best options I can provide for my employee base? Right? How can I manage that cost in my business, but also provide the value my employees need? They listen. The employers want to know what's best for their employees, what their experience is working with the carriers. And, as it relates to the provider community, we find people are very particular about where they want to get their care, right? You can offer limited products and try to get people to go and think about the cost of something when they're going to get the care. But New England at large is very, very adamant about where they want to go, right? They have their connections, they have their people, they go to their providers, they're their neighbors, their friends. We have rich options here, right? Whether it be in the Massachusetts hub of Boston or here in New Hampshire or another state. So it's part of the conversation for sure, but who's buying it and what those needs are becomes an important piece to it.
Well, and I also think when you talk about value, there's so many different pieces of value in the healthcare system, and specifically at the provider level. And we talk about speaking in terms that are relatable. And so, I'll talk about, cancer. I think it's very well known that if you seek treatment early and cancer is diagnosed early, you have a better chance of treating it and curing it than if you never get treatment and you're diagnosed at stage 4, stage 5, right? Most people can understand that. So when we talk about delivering value in the provider space, from my perspective, it's about looking, if you work, and we do this a lot with and I think our providers in New Hampshire have been great partners in this state, and that's working with carriers. To your point, it is our responsibility in part to bring value-based care to this market. And what I mean by that is, if we are working with providers on value and not volume, not how many people you see a day, but if you see 10, how much healthier are those 10 than if you were seeing 20, you can pay providers more for better outcomes. And I think that shift, like that I would say would be a big difference in the mass market in the New Hampshire market. We're nowhere near value in mass. We are there in New Hampshire in part. And so I think because Kate, I think you're right. Where we all want to go where we want to go. But if we saw that if we were going to this primary care practice, that over a 5-year period, working with those doctors produced better outcomes and less stage 4 cancer because they're doing the right screenings at the right time, at the right age, who wouldn't want to go? I mean, that's why, DJ, you mentioned everybody wants to go to Boston because we think it's better health care, right? But do the studies show that? Does the data show that? So I think it is incumbent on us, and I think we're doing this with partnerships in this state with providers, where providers are stepping up and they're saying, rate me, like show my quality, like I'm proud of what I'm doing. I just think we have to do more of that, because that the value isn't always inherent, especially if you never use services. How do you know you're getting value? You're like, I'll just get rid of it. I don't use this. But if you know the PCP you're going to really is looking out for you, not just today, but 10 years from now, you're much more likely to engage in the healthcare system. And that's what we need. We need people engaging before they get sick.
There's a question I asked my insurance broker, and I asked also my financial advisor every time we talk about something. I said, if it was you and your family, what would you be doing right now? That's where you start to see the real answers, because if you ask a broker, they have the information, right? And they understand it. Same thing as someone came into my restaurant and said, what would you eat tonight? Well, I'm going to tell you what I would enjoy, right? And I know it's going to be something you will. So I think that's really important as far as brokers go, is sharing that information about what's the value to them too.
We have another online question, and I know there's been a lot of focus recently on, well, not recently, but for a number of years on being and staying healthy to keep utilization down, I think, from the carrier's perspective, and certainly prices from everyone's perspective, or just being healthier. The question that they pose is, has there been any research on how the citizens of New Hampshire's health compares to other states? And then the second part is, I think referring to utilization, do we have any information on our utilization compared to other states?
Well, there's that the healthiest state in the nation report that just was released. We did well. We weren't in the top 5, but
Is this that program when they send you a check for like $25 because you went walking? Is that what we're talking? You guys know that? Does anybody sign up for that? My wife made me start doing stuff. I mean, I started going to the gym because of it, so she'd get a $75 check like once every. Yeah, it's a reimbursement. So.
Be healthy.
Yeah, it was a lot of work, but it's worth. I mean, there's a positive to it. It got us to a gym and stuff like that. So.
Well, I mean, like we did an analysis internally. There was this supposition. I was talking to a bunch of brokers. Do we have more cancer in the state of New Hampshire since COVID, right? Because the belief that everybody delayed care, they didn't go to the doctors, they didn't get their proper screenings. And so not is there more cancer in general, but is there more severe cancer? And that's why costs are going up. So, we looked at it with our team, with our data team, and it's only our data, so based on our population, over, a 4-year period to say, is this right? Are we seeing more stage 4, stage 5 cancer? We saw the opposite in our data for our population, where we don't see we saw an increase in screenings, ironically. So diagnosing, so we're not getting to stage 3, stage 4, stage 5. We're finding it early, treating it early, so it's not producing more severe cancer. That, again, so we do this. I think each of us probably do this. I'm sure all carriers are looking at their claims and trying to say it, because then we say, do we need more programming in New Hampshire or do we need to do more promotion of cancer screenings? And, I was pleasantly surprised, with the results of our analysis, and I was able to say to the brokers, we don't see anything in our data that suggests that. I understand why people will think that, but I think the point is, look at the data. There's a lot that people think about healthcare. There's a lot of data out there. And, I think, the data that was used today, I think the department is about to do the annual hearing. They've taken a lot of data from the carriers. They're synthesizing it. And I think it's just important that we make decisions based on data.
There is the fire state health assessment that was just completed.
Good news. There you go.
Does it say we're healthy?
In some ways we are, in some ways we're not. Diabetes, not so much. Treating asthma, not so much. Dental health, not so much.
How
does that relate to other states, though? And I guess that's a question. Yeah. In relationship to other states.
Great. Other questions? Anything further online, Andrew?
We have one more from our friend Michelle at the Mount Washington Valley Chamber.
Yeah,
and
she was watching.
Yeah. Thanks, Michelle. And she's asking about what we already discussed in terms of collaborating and working together to offer health benefits, small businesses to their staff as a group.
Sure. I've written on this topic, Andrew, and we can get those materials out to folks so they can understand the current landscape, the current dynamics, what's going on there. There's certainly a conversation to be had about that. What I would say is we do have a number of advantages in New Hampshire. I think regardless of the study, we have very high quality of life metrics across the board. We're not perfect, of course, but we do have a lot of advantages that other states do not. And that obviously puts us in a better position to be able to tackle the challenges that we do have. But there's just no question that the utilization issue is a huge one in comparison to cost. And we're not immune from the nationwide dynamics of the fact that there was a lot of deferred care during the pandemic. And some of that has been and will continue to come home to roost for us and for states across the country. So with that all being said, we will wrap up right on time, which I'm sure you all appreciate. Again, I want to thank our panelists for a phenomenal discussion, our friends from Oliver Wyman, Maria, Bill, Kate, and Luca for joining us on the panel. Again, I want to thank my staff, and particularly Curtis and Alex, who really made all of this happen. Lee did a phenomenal job seeking out the federal grant that drove this whole process, and Alex bringing his expertise and background, Michelle Heaton as well, though she stepped out. Really phenomenal discussion this morning. Special thanks to those members of the staff. I want to thank UNH School of Law for being a gracious host, as they always are. And for those of you who just cannot get enough of this, we will be right here on October 25th, same room, same start time, 9 a.m. for our annual hearing on healthcare premiums and cost drivers. And we'll get into detail on a lot of the issues that were raised this morning and other things as well. So invites to that are out or will be going out shortly. If you need information about that event, let us know and we will get you everything you need to know. But for now, thank you all so very much. Have a great weekend. Be well.